All right, today we are doing a deep dive into one of the most incredible, most dramatic drugs in all of emergency medicine, adenosine. Seriously, if you've ever wanted to know how to chemically stop and restart a human heart in less than 10 seconds, well, you are in exactly the right place.
So let's set the scene, because you are absolutely going to see this. A patient rolls into the ER. They're anxious, they can't catch their breath, and you get them hooked up to the monitor. And you see this. A heart rhythm that's perfectly regular, but it's flying. Over 180 beats per minute. Their blood pressure is starting to get soft. You've got to do something, and you've got to do it now. The clock is absolutely ticking. You need a tool in your kit that can basically reboot the heart's electrical system, and it has to work instantly. So what are you going to reach for in this exact moment?
Well, what you're looking at is a condition called paroxysmal supraventricular tachycardia, or just PSVT. Supraventricular just means the problem is starting above the ventricles. What's happening is a re-entrant arrhythmia. Think of it like this. An electrical signal has gotten stuck on a tiny circular racetrack inside the heart's wiring, usually right around the AV node. It's a short circuit, creating this feedback loop that just goes faster and faster and faster.
Okay, so here's our solution. This totally unique drug called adenosine. And listen, it doesn't just slow the heart down. It acts like a pharmacological control-alt-delete. It literally slams the brakes on the heart's conduction system for just a moment, stopping that out-of-control arrhythmia cold and giving the heart's natural pacemaker a chance to take back control.
Now, what's so cool about adenosine is how we classify it. Yeah, it's an antiarrhythmic, but it doesn't really fit into the standard class 1, 2, 3, or 4 drugs you learn about. It's kind of in a league of its own. Its number one job, its primary indication, is to terminate PSVT. It's also fantastic for arrhythmias that involve a little shortcut or an accessory pathway, like you see in Wolff-Parkinson-White syndrome. So how does this reboot actually work on a molecular level? The real magic of adenosine, the whole story, is all about its incredibly short but incredibly powerful mechanism of action. It all happens in a flash, but it's a 4-step process. First, adenosine binds to these specific A1 receptors on the heart cells. This does 2 things at once. It opens up potassium channels, letting positive potassium ions rush out of the cell. And at the same time, it blocks calcium from coming in. All this makes the inside of the cell way more negative. We call that hyperpolarized. And that makes it really, really hard for the cell to fire an electrical signal. It basically just stuns the AV node, which is the weak link in that PSVT circuit, and boom, the loop is broken. The tachycardia is terminated. And here's the absolute crucial point, the key to the whole drug. It's pharmacokinetics. Adenosine has an insanely short half-life, less than 10 seconds. You push it IV, so absorption is immediate, but the metabolism is what's key. It gets eaten up by enzymes inside red blood cells and the cells lining your blood vessels all over your body. This means its entire profound effect is over almost as soon as it begins, and that is a huge, huge safety feature. It doesn't even stick around long enough to get cleared by the kidneys. Now, because that half-life is literally measured in seconds, how you give this drug is critical. I mean, it's everything. If you push it too slow, or you use a tiny little IV way down in the hand, the drug will be gone before it even gets to the heart. Your technique has to be perfect. So, first things first, the patient absolutely must be on a continuous heart monitor so you can see what's happening. You need a big, reliable IV, and you want it close to the chest. The antecubital fossa, the AC, is perfect. The standard adult dose starts at 6 milligrams, and you push it as a rapid bolus, like bam, over 1 to 2 seconds. And right behind it, you immediately slam in a 20 ml saline flush to basically jet propel that drug to the heart before it disappears. If that doesn't work, you can come back with a 12 milligram dose. For kids, by the way, it's weight-based, usually starting at 0.1 milligrams per kilo. This is, without a doubt, one of the most important things you will say. You have to tell the patient exactly what to expect right before you push the drug, because for them, the experience can be really scary if they aren't prepared. Clear, calm communication is non-negotiable here. The second the drug hits their system, patients feel a really intense but very brief set of side effects. The classic ones are this sudden wave of heat and flushing in their face, a heavy pressure or even pain in their chest, and a profound sense of shortness of breath. A lot of patients describe it as a feeling of impending doom. And on the monitor, you'll see a brief pause, maybe a few seconds of a flat line, before that beautiful, normal rhythm kicks back in. You have to tell them this is normal and it'll all be over in less than a minute. Okay, so let's talk about the safety net. Adenosine is incredibly good at what it does, but there are a few scenarios where it is a hard no. You absolutely cannot use it. The two huge red flags you have to burn into your brain are asthma and high-degree heart block. In patients with asthma, adenosine can trigger a severe bronchospasm. It can clamp down on their airways. And for patients who already have a second or third degree AV block, well, giving them a drug whose whole job is to block the AV node even more is a recipe for disaster. You also stay away from it in sick sinus syndrome, unless they have a pacemaker, and of course, if they're allergic.
All right, let's wrap this up with the high-yield stuff, the clinical pearls you need for your exams and, more importantly, for the real world. This is the stuff that separates the novices from the pros.
To keep your patients safe and to calm their anxiety, please use the teach-back method. After you explain what's going to happen, have them repeat these three things back to you. 1, this weird feeling is normal and it means the medicine is working. 2, it's going to be super short. And 3, we are right here watching you and your heart the entire time. And here it is, a classic board exam trap. Caffeine is an adenosine receptor antagonist. It literally sits on that A1 receptor and blocks adenosine from doing its job. So a critical question to ask your patient is, have you had any coffee or energy drinks today? Because if they have, that 6 milligram dose might do absolutely nothing, and you might have to go straight to a higher dose. Now this is a massive safety pearl. Sometimes it can be really hard to tell if a wide complex tachycardia is SVT with some funny-looking conduction, or if it's the much more dangerous ventricular tachycardia, VT. If you give a drug like verapamil to a patient in VT, you can cause their blood pressure to crash and send them into cardiac arrest. But if you give adenosine, because it's gone in 10 seconds, it won't cause any prolonged harm. That makes it a much, much safer choice when you aren't 100% sure of the diagnosis. So what's the big takeaway here? It's the incredible power and really the elegance of adenosine. Think about it. It's a drug that lets you turn a cardiac emergency into a stable rhythm in the blink of an eye. Understanding its mechanism, how to give it, and when not to give it, that is a fundamental skill for anyone in medicine.